here is our patient, and I want to start with an apical view, with a 4-chamber view, just to give you an impression of hypertrophy in this patient. So it's quite clear that the patient has hypertrophy. And the question is, does the patient have hypertensive heart disease, or does the patient have hypertrophic cardiomyopathy? So when we look at the different segments, and we can see that most, or actually all segments have the same wall thickness, so this speaks in favor of a hypertensive heart disease. And if we look at the apical segments, we see that the apical segments are not more hypertrophied than the rest, so this does not look like an apical hypertrophy, but more like a concentric hypertrophy. The other thing we see is that the patient does not have obstruction of the LVOT. There's no SAM phenomena, and also with color we see no turbulent flow. And if you also take a look at the short axis view, you can see that hypertrophy is concentric. So all segments have approximately the same wall thickness. Certainly hypertrophy can also be asymmetric in patients with hypertensive heart disease, but this altogether looks very much like hypertensive heart disease. So if you look at the clinic as the patient as well, and you know that the patient had hypertension for many, many years, the diagnosis is quite clear. Okay, so are you ready for the next case? This is another patient with left ventricular hypertrophy. So let's take a look first at his parasternal long axis. Again, we have left ventricular hypertrophy. Now let's turn to the short axis. And there's no question, the septum is very thick in this patient. Let's just measure it somewhere in this region. Now this is 33 millimeters, which is severely hypertrophic. But opposed to the patient you saw previously, hypertrophy is not symmetric, but different regions of the myocardium show different wall thickness. For example, if you measure the wall here in this region, it's almost normal, it's 13 to 14 millimeters. Or if you measure the posterolateral wall, it is much less, 15. And even within the septum you have differences with respect to the thickness of the wall. So this is an asymmetric pattern of left ventricular hypertrophy, which is very indicative of hypertrophic non-obstructive cardiomyopathy opposed to hypertension, where you can have some degree of differences with respect to the thickness of the wall, but never to that degree. In addition, the speckled appearance of the interventricular septum and the myocardium is also in favor of hypertrophic cardiomyopathy. What about the sigmoidal septum? Or what is the sigmoidal septum? Well, it's a thickening of the basal portions of the interventricular septum. You can see here. And it also predisposes to LVOT obstruction. Here we have a SAM phenomena. This is not a patient with hypertrophic cardiomyopathy, but he still has an LVOT obstruction. This phenomenon is often present in patients who have hypertension or hypertensive heart disease, so usually there's also some degree of left ventricular hypertrophy in these patients. It's typically localized to the basal portions of the septum, and as already mentioned, it enhances or increases the risk of obstruction, especially if confounding factors are present such as hypovolemia or a hyperkinetic left ventricle. So this is an example of a patient who has mitral regurgitation and also an LVOT obstruction. You can see the continuous wave Doppler sample volume passes right through the mitral valve, and this is the signal we get. This signal also has a dagger shape, but it is not an LVOT obstructive signal, but it is mitral regurgitation, which can also have this shape. How do we differentiate the two? Well, the MR signal generally starts earlier, right after the QRS complex, and the signal usually has a velocity above 6 meters. If you take a look more closely, you can see that we also have a second curve within this curve, and this curve is also an obstructive signal, probably an obstruction located in the mid-ventricle. So we have two signals in one. If you want to differentiate these different signals, it's always very helpful to use color Doppler as a guidance. Here we have a patient who has both LVOT obstruction and aortic stenosis. So you can see there is concentric left ventricular hypertrophy. The ventricle is very hyperdynamic, which predisposes to obstruction. And here is the SAM phenomena of the anterior leaflet. And the patient also has mitral regurgitation. If we place the Doppler sample volume in the LVOT, we can see the typical shape of dynamic obstruction. This is the LVOT obstruction. If we move the Doppler sample volume a bit, we can see that there is aortic stenosis. We have very severe aortic stenosis. The signal is more symmetric opposed to this signal. So you can differentiate the two different signals if we just play around a bit with the continuous wave Doppler probe. Finally, a few words to septal alcohol ablation. This is a technique which helps to reduce the gradients in the LVOT by causing an infarct of the septum. What do? We inject alcohol into a septal branch and thereby occlude this branch, and this causes thinning of the septum, a reduction in the SAM phenomena, and a reduction in the LVOT gradients, at least in most patients. But what are the recommendations to perform this procedure? First of all, we have to have therapy refractory heart failure, class 3 or 4, and we also have to have gradients in the LVOT over 50 millimeters mercury, either under basal conditions or under provocation with physiologic provocative maneuvers such as stress tests. Here's an example of what we can find after the procedure. So this is a patient with hypertrophic cardiomyopathy, and I want to point your attention to the basal septum. We see that it's massive left ventricular hypertrophy, but this portion of the interventricular septum is much thinner, and there is a fairly abrupt change in the thickness of the septum. And if we go into the two-chamber view, we can also appreciate that here in the two-chamber view, and the wall motion is also abnormal here. It's akinetic in this region here of the basal inferior wall. And if we take a look at the short axis view, this is the short axis view. This can also be noted here. So, basal inferior septum, wall motion abnormality, thin myocardium. So this is indicative that the patient had alcohol ablation of the interventricular septum to reduce the thickness of the interventricular septum and thereby reduce the gradient. And let's take a look if the patient has a gradient. So this is the continuous wave Doppler. And normal LVOT velocity, no gradient, because the septum had been reduced by alcohol ablation. So as you saw in this chapter, echocardiography is extremely helpful in patients with hypertrophic cardiomyopathy, not only in making the diagnosis, but also, for example, to determine which form of hypertrophic cardiomyopathy is present, and to determine if we should proceed to other therapeutic strategies, for example, alcohol ablation. We can also use echocardiography to determine the results of this procedure, and maybe even to assess the risk. For example, patients who have a septal thickness of over 30 millimeters might be at increased risk for sudden cardiac death. So these patients maybe would be candidates for an ICD implantation. There are still some questions which are open. Specifically, can we actually detect patients who have subclinical disease and subclinical hypertrophic cardiomyopathy? And are there other ways of looking at cardiac risk and risk of sudden cardiac death in these patients with the help of echocardiography? But now, let's summarize all that we've learned in this chapter.